Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Darby Smith, the residency coordinator for the Memorial Hermann Acute Care Residency Program. We discuss use of outcome measures in acute care, how to incorporate them into your practice,
And how you can get a sneak peek at the Acute Care Court Outcome Measure CPG. Let's welcome our guest.
All right, today's guest is Darby Smith. She is an acute care therapist. She graduated from the University of Texas Medical Branch in Galveston, Texas, 2020. She completed the Memorial Hermann Acute Care Residency Program at Texas Medical Center 2021. She's currently employed at the Heart and Vascular Institute at Memorial Hermann Hospital, Houston, Texas. And now she serves as the residency coordinator for their acute care residency program. On top of that, she is also an adjunct professor at the University of Texas Medical Branch, where her primary focus is teaching content regarding PT management in critical care and the cardiopulmonary system. Darby, welcome. Thanks for joining us today.
Thanks for having me. It's good to be here.
Now, I would say the first time I met you was, I think it was during the journal club Bobby Bellarmino had put out together. And so I helped host that. And that was the first time I met you. And the topic was on a recent paper that you had helped publish, right, regarding outcome measures. Can you talk a little bit about how that even got started?
Yeah, so that the perception and utilization of outcome measures in the acute care section, that was my research project during my residency year. And so I've always kind of had an interest in outcome measures. And so and kind of wondering why I always knew like, oh yeah, we're supposed to be using outcome measures and there's like all these benefits to them. But then like I really saw it, and especially like in my rotations as a student, and then, my first couple of months working in a hospital, during residency, I kind of saw that like, yeah, some people were using them, but like not everyone. And so I was wondering like why I can see how it, and then I got used to working in acute care and I was like, oh, I can see how there are these barriers to all of these, to using these, even though we know we should be. And so that kind of sparked that curiosity of that. And so put together really a survey and started out just with the therapists in my hospital and then kind of extended to a couple of our key hospitals within the greater Houston area. And then was able to kind of get in touch with the acute care section to kind of spread it out wider. I had a lot of connections with other residency programs since I was a resident at the time. So we're able to kind of distribute it a lot wider than I ever thought it would be. And so I had, done all this work of putting together all those presentations, and my mentors at the time, who are my other co-authors, Greg Rizzola and Michael Furtado on the paper, they were like, you should really, present this at CSM, or you should write it up. Like, you have the time now, as a resident, and I had the resources. And they're like, you should really submit this for publication. And so they were really kind of my champions in that, and forever grateful for their mentorship on that. And ended up going through the whole process and finally getting it published. And I'm really grateful that they pushed me to do that, because it was really cool to say like, oh, I've been out of school for, I think at the time it was maybe like a year and a half, and I was like, oh, and I've been published. So I never really had like that drive to do research in school, but I really kind of found my love for it throughout that process.
So I'm curious what you learned from publishing that paper. Can you give us like a summary of an overview of like if we had read the paper, or if someone hasn't read the paper, what's the takeaway from that paper?
Yeah, I would say the main thing is that really we know the benefits. The benefits are highly documented throughout research, but there is this kind of gap in the acute care section of, what is being utilized and why. And there's a ton of research on there, like barriers and facilitators to research. And a lot of it is focused on like outpatient or very patient population specific, like the neuro section and orthopedic section, I think have done a fabulous job of documenting all of that research. But there really was that gap in the acute care section, and just kind of a wide variety. I work and I did my residency we're a level 1 trauma. We see a ton of different patient populations. And so I had a wide pool of being able to kind of experience that. And so really, I think the key takeaway is that there are these documented barriers of the time and the productivity concerns and just the kind of acute nature of patient populations and like the diversity of it. And I would say the biggest barrier for most people that I found in the research is the resources. They want to use it, but they don't know how to
Mm.
get started. And so, but there are all these facilitators. And one of them that we did find was that having some sort of specialization or residency trained or fellowship trained, and we even included in there being, CI certified, that they're more likely to use these outcome measures. And they're also more likely to find that the barriers, that resources are not a barrier. And so we can kind of see that with these specialization trainings and with these residency and fellowship trainings, and even with CIs. So we see those people that are like really continuing wanting to learn throughout, their careers. We see that they know how to find the resources they need and they're more likely to use these outcome measures.
Yeah, it
I
was
think some people are
fascinating.
just go ahead, Ashley.
Oh, go, Leah. Go ahead.
I just want to say, I feel that sometimes clinicians just kind of get into the same old rut, the same old cycle, and it's just having to change their behavior or to change their practice. It needs a little bit of activation energy, right? And as I think looking at that paper, one of the things in terms of barriers, they had mentioned that if structurally, if it's actually part of the documentation, or if management or supervisors are saying, now, okay, you have to use this, or you at least have to use one, then it kind of helps incite those therapists to kind of change some behavior. Was there anything else that you kind of noticed in terms of difference between those therapists that do use the outcome measures versus the ones that don't?
I think one of the main things is that some, and it's hard, and this is where we found some trouble in the hard part of coming up with, a core outcome measure set for the acute care section is that we are seeing such a wide variety of patient populations and there's such a wide variety of acuity level that I think that clinicians kind of find it hard, and it may be easy to say, like, "I'm gonna use this one outcome measure on every single one of my patients." And there are some measures that I think that that could be beneficial for, but there are some that, like, maybe that measure isn't the best suited for that patient. And so I'm a big believer that there is not one fits all outcome measure for every single patient that every single therapist is gonna see. I'm a big believer of that, and I'm also a big believer in knowing that, like, if you think this outcome measure that a lot of hospitals require a certain outcome measure to be used, which is great. I think, like to what you were saying, Leo, that it gets you ingrained of doing that every day. And when it's part of your EMR and you're supposed to do it, it just becomes second nature. It doesn't seem like you're having to do anything extra.
Mhm.
But if you think that that outcome measure is not appropriately capturing the impairments your patient has, then, on where we have to become, we have to think outside the box and say, okay, what impairment am I trying to capture? And what outcome measure knows that and can capture that impairment best so that I can show what you're needing to show, whether that's my patient needs more therapy, my patient needs a higher level of care, after this acute care stay, or my patient's doing great and they're showing improvement and they're not needing my services or they're not needing this level of care. Whatever you're trying to show, that being able to kind of know a good couple of outcome measure sets that you can use on the patient population that you normally interact with to be able to show what you need to show.
It was
Such a
interesting to
great
me
point because I also feel that. Go ahead, Ashley.
Oh, no, I was just gonna say it was interesting to me in the paper that, like, the most frequently used one by most people was the 5 times sit to stand, and that was even true across all the different specialties like neurocardiopulm and whatnot, and like, it really doesn't take that long, and so it was interesting to me also that the biggest barrier was time because I feel like you hear that a lot, right? Like, I just don't have time to do an outcome measure, and that's always been a pet peeve of mine. Like, I teach my students all the time, I'm like, "Well, you do have time," because I think some people don't think about, like, doing an outcome. It's not like I have to do my evaluation and then do my treatment and then do my outcome measure. Like, I can do a 6-minute walk test. I can be evaluating during that. That can also be my treatment because that's challenging that patient. If I do a 5 times sit to stand, right? Like, that's also an intervention because my patient's getting to stand up and sit down multiple times. So it's always interesting to me that people say they don't have time when really, like, the outcome measure can be part of your intervention session. It doesn't have to be like this separate thing. So I'm curious how much you come across that in some of your work with outcome measures.
Yeah, I would say mostly when it comes to with teaching students, residents, new employees, things like that. I see that a lot, and I try to emphasize that fact of, and
Yeah.
I experienced this when I first started, especially when I was a student and when I first started in residency. That like there is this like kind of overarching like almost like cloud of like outcome measures that like it does have to be this separate thing and it has to be this very standardized, strict. I have to know exactly how to do it and it has to be exactly how
Yeah.
it's done. And I think there are definitely some outcome measures that if you want to be able to get accurate data and you want to be able to compare that to other, you know, patients in that age category or that diagnosis, or you want to use it for research, I think that's definitely you do have to follow those strict things. But sometimes we just need an outcome measure to compare patients to themselves. Um, some of my patients react really well to being like, what can I work on? And my patients love to respond to like the 30-second like sit to stand or 5 times sit to stand because they can do that on their own. I'm not there. And I'm like, great, you did this in 20 seconds. And, by the end of the week, we're going to try to do this in, 17 seconds or whatever it may be. And they can practice that on their own. So giving this patient like more autonomy. And I think when I was a student and definitely a new resident and just kind of like new to working, I did have that overarching gloom, and I think that the more that you really look at the outcome measures and say like, "Okay, actually this, like, test doesn't have this very strict script or this very strict setup or very specific thing that I need to follow. I can very easily incorporate this into my evaluation or my treatment or whatever it may be." But the more that you do it, the easier it is to incorporate. But I think there is that time of, clinicians and students and residents adjusting to that and taking that realization. And, I think that that is where I will preach to residency all my life that it really gave me the time and the opportunity to be able to learn those things without having the pressure of like this productivity and, being this new clinician and all the other things that come with just kind of working as a full-time, clinician, taking on all the other things. It really gave me a chance and opportunity to see those things. And I think that's where I learned it the most. And so I think it just takes a little bit of like maybe some mentorship and giving new employees or new students or new residents, whatever it may be, just like that time to adjust to say, like, how can you really incorporate this? Like, let's look at these outcome measures. Take 30 minutes and look up 5 outcome measures and see like how could I incorporate these into my treatment sessions really easily. But I think that's what we're missing. And we're saying like, oh, there's not enough time because clinicians that have been working for, X amount of years, they may not think they have the time to sit down and take X amount of time to be able and say, okay, I'm going to look at these outcome measures and see how I can incorporate it in. But then I think that's a great opportunity for, those champions that are using outcome measures or those clinicians that are, specialized in some sort of something of being like, you don't need to look them up. I'll look them up and I'm going to give you a presentation on it over lunch for 30 minutes. And like, I think that's a great way for people to really champion getting other clinicians to use outcome measures. It's like, look, here's how easy this is to incorporate this is. And here's how time is not a barrier. Here are these resources so that resources are not a barrier. The more that you provide those for clinicians, the easier it is for them to be able to change their everyday practice.
Yeah, I agree. The more
Darby,
you
it's funny too that you mentioned. I think that's also that's part of the skill, right? Just choosing the correct outcome measure. I've had students tell me just kind of trying to understand, wrapping their minds around from acute care, especially those that only primarily like outpatient experience. And so they're just trying to figure out, okay, where's the skill in acute care? Part of that is choosing the right outcome measures. I'm going to give a shout out to one of my students. I have a student that's on his third clinical rotation, that's second to last, and he needs to find a case for his case report, kind of the big case report at the end of his tenure there. And he said, Dr. Leo, I'm on an acute care rotation. He's only had his first week. And he goes, I don't know what outcome measures to use because with acute care, I'm only seeing patients like times. I don't know where to start. I said, we're going to be meeting a little bit. So Connor McCarthy, if you're listening to this podcast out here, I'm mentioning you specifically. Now I've got two people, that I can give you maybe some background. So what he had stated is that he only has short exposure to some of these patients. And so he's not sure if he's going to be able to get any outcome. Now, hold on. Let me ask some experts here and get their opinion.
Yeah, and I think that that's great, and I love that he's asking those questions because I think that's the first step. Like, what knowing that I should be doing these outcome measures and like, what am I going to choose? You know, I personally, like Ashley said, I love a 5 times sit to stand. I love a 30-second chair stand test. I think it is kind of the easiest thing to easily incorporate, and I think it gives you a lot of information. And then I would say, look at your patient population. You know, are you in a cardiopulmonary unit? You know, would a 6-minute walk test be more appropriate? Are you trying to look at someone, what are you looking at? Do you want to look at their functional capacity? You want to look at their strength? Do you want to look at their aerobic capacity? Because are you in the ICU? There's tons of very specific ICU measures that really take into account like what are these what lines does my patient have? What kind of other external support are they having? You know, PERMI ICU outcome measure is something that I personally love, or just a simple, we use an AMPAC on every patient, every PT encounter at our hospital. That's one of our required outcome measures. So, and I think it's great to show progress along time. I think there are some downsides to it, just like there are in every outcome measure. But those would be my first couple of, first guidance of if you want a quick and easy one just to see how your patient's doing. Like I love those 5 times sit to stand, 30-second seer test. And then if you're looking at something more specific, then like what are you trying to look at? And then find the outcome measure that looks at that.
I think it's a
Awesome.
great point you bring up to just like find an outcome measure that like that you really like, that's really easy, and just start practicing it and doing it on patients, because the more you practice it, the easier it gets. Because I feel like it's also easy when a patient's walking to just start a stopwatch and stop it, right? Grab a gait speed or the AMPAC. Like the AMPAC is a really quick and easy one too that a lot of people I know like to do, because you don't really have to think about it in the moment necessarily. But you mentioned like the outcome measures in general, and I know, like, the neuro section or Neuro Academy has their core outcome measures, and the Acute Care Academy currently is coming out with this core outcome measure publication, and I only know this because 'cause I'm on task force for knowledge translation for these outcome measures, but it is out right now, like, for the public to comment on it. So I would love for you to talk a little bit about kind of like what stage are you all in right now with this APTA Acute Care Core Outcome Measure set? Because I know there's been a lot of hype about it at CSM and conferences, and people I think are really looking forward to it. And you don't have to give anything away, but I think if people want to know, like right now, they can actually go read it and give public comment on it. So can you please talk about kind of where you all are at with that? And if you can share anything, what can you share?
Yeah, I think so. There's eight, like kind of our core eight that have been working on it. We've had a ton of help from other clinicians, whether that has been in data retrieval or just writing the manuscript or guidance and coming up with this CPG. And so I think all right now we're kind of just like taking a breath. We're relaxing because we got it out, and it's been a labor of love. So I came onto this project myself, and the three other residents at the time of 2020 came onto the project with the four main authors that were there before us that had done many years before that, before we came on. And so it's definitely been like a labor of love. And I will say I didn't think that any of the residents at the time that we got onto it kind of like knew what we were really getting into. It's been like a 4-year project. But I'm really thankful to be a part of it because I've had some really great and really cool conversations about outcome measures regarding it, and just really just like how it gave me another appreciation of CPGs in general because they are so much work and they give so much information to our practice. And I never realized I really took CPGs for granted before. I never realized how hard they were put together, how hard they were to, get out. So it is available for public comment right now, I believe until September 15th. And so you can look at our current draft of our manuscript. The full manuscript is available. And then there's a survey of where you can give feedback and public comment of, and we're taking that from everyone, not just PTs, PTAs, but other disciplines, from patients, from doctors, from anyone. We want comments from everyone. We want everyone's opinions to be able to take into account so that we can provide the best CPG that we can to our clinicians. And so right now there are that, we tried to cover and took into account, had a ton of conversations about, you know, being able to, one, take into account just clinician preference and the availability of outcome measures, the time limit that it takes to incorporate these outcome measures, their ability to be accessible. So, are they free? Do they require a fee? We try to take into account the ICU versus floor level patients versus IMU, like that wide acuity that we're going to see all inpatient population. And then also being able to take into account of these things that can, one, either be used across the continuum of care or be used in different patient populations. So there are outcome measures for the ICU patient, for the cardiopulmonary patient, for the geriatric patient, for, just all of the adult patients you may encounter. And so it has been has been a labor of love. I encourage everyone to go look at it. And if not, even to look and see, like, okay, what are these outcome measures that are like going to be a core part in the coming days, the coming years of our practice in acute care. And I think that you'll kind of find that, oh, I actually do know these outcome measures because they are widely used. And there might be a couple that, personally, there was one that I was like, I've never even heard of this outcome measure. But then you look at it and you're like, oh, actually, this is like very beneficial. And like I can see where it could be used in practice. So
I know which one you're referring to, I think.
and so, and they're all, they're evidence based, and there's a lot of data and research that went into them. And so, and I think that what we found too is that even with looking at all of this data and all of this research, that there may be outcome measures on there that you as a clinician may think like, I think this one should be on there, or, I don't think this one should be on there. But when you really look at the research, there may be an outcome measure on there that maybe we personally thought should have been on there, but the research isn't there. Or it's not there in acute care. And so that's why we encourage clinicians, if you have a strong preference on an outcome measure, go do the research. Go do the research.
Yeah.
And so that way, when this is updated, maybe it is in there. But that's where we're finding those gaps in research and acute care. And so I think that's where most people may find that, like, oh, the outcome measure I really love isn't on there. Well, there might have been a research gap on there. So go and do the
Yeah.
research and
That's the
and
critical
look.
part with CPGs is you're limited to the evidence that's out there. You can't put something in there if the evidence isn't there to show it. So, Darby, if people want to go comment, because I think we're not going to give it all away on this podcast, right? They need to go read it. So, where can they find this CPG for public commentary right now?
So there was like a mass email that went out from the acute care section. It has, I believe it's been posted on the acute care Instagram, APTA. You can find it on the acute care section on the APTA website. We are trying to get it out as much as we can. And I am sure that it will be, by then we'll be done. But with time CSM comes up, we'll be done with public comment. But I'm sure we'll have some great presentations for our knowledge transfer
Yeah.
committee.
I did get the emails, so you're
Yeah.
right. They are out there. And I would say if you want a sneak peek and if you want to give input on it, now is your chance. So
Yeah,
go do that.
definitely.
Well, now while I have both of you here, can I ask you actually what knowledge translation is up to in terms of, are y'all just kind of waiting until you get the results, or what point is, or how's now the knowledge translation group? How are you interfacing with the researchers?
Yeah, we've actually met with the guideline development group, the primary authors, a couple of times already, or a few times already. Definitely lots of emails back and forth. Mostly,
Yeah.
where are you all stand on this? Because some of our work can't be done until the publication is actually out. But we have done a lot of pre work on developing some protocols for some of these outcome measures. So we've been looking some of them up, developing. We've developed some tools already that we're just kind of waiting now to see, but we didn't want to get too far down the road with our work until we knew, which measures were gonna for sure gonna be on the CPG. So I think we've been on hold for the last few months waiting for this public commentary. So we're excited now that this is finally out there. And once it's published, I think our group's gonna we're going to really get back to work on putting out some things for the public and for the clinicians to be able to make these outcome measures more easily accessible and actually give them tools to actually help put it into practice, which will be really nice.
That's awesome. That's great. I'm in the presence of greatness between the two of you. And hopefully, I think, and for all the clinicians out there as well, and the instructors, I think it'd be great to familiarize yourself and then making sure that the new students that are going through DPT programs are familiar with these core outcomes because I mean, we need to use them, right? And so I think very often students that are unfamiliar with them during their actual didactic portion of their training are underprepared once they go out into the clinic and once they go out into the actual workforce in these hospitals because, clinicians are out there using them. So it'd be best for them to be
Yeah.
prepared. And I know with my students, just making sure that, I've even incorporated use of outcomes in some of the practical exams. So they start getting used to, all right, I've done my assessment, I've done my exam, but what would be the best outcome measure to utilize within this given time frame? I have a limited time frame, but I still have to make sure that an outcome measure gets utilized.
Leo, you're right. I think it's going to be such a great tool when this publication does come out. And Darby, thank you for the work you and your team have done because I think it's going to give educators who are teaching students a great resource. I think for clinicians who are out there practicing seeing patients, it's going to be a great resource. And I think it's just going to be, it's going to be interesting though, because, we have this acute care, I think covers all kind of specialty areas, right? Like you might have a neuro patient in acute care, a cardiopulmonary patient in acute care, an ortho patient in acute care. So I think it's going to be interesting to see how the knowledge translation group works with that because, where there's also the neuro core outcome
Mhm.
measures. Now there's the acute care core outcome measures. And so we're going to have to come up with some way to say, well, yes, we have this acute care one, but also if you have a neuro patient. So it's going to be interesting to see what kind of tools come out for clinicians as well, kind of cross referencing some of the other outcome measures and trying to make it as easy as possible for clinicians to be able to select the right one for the right patient at the right time.
And I think that's the key part is that, the clinicians, the people that are working every single day, like those are the people that really have to champion using these.
Mhm.
And so, I highly encourage that any clinician that's listening or that ever sees this, that, you are the one that can change, implementing these. And so like if you have to start with yourself, of you implementing them and then champion that in your hospital. I'm sure my leadership team is maybe a little tired of me talking about outcome measures. So, but I think that helps, make our practice better and our hospital better and it works better for our patients. And so I think you really have to kind of like champion that at your own hospital. I think it starts at the clinician level. And I think the knowledge translation and the ATA and the acute care section is great. They're going to be fantastic at getting out the resources that we need, but then the clinicians have to take those resources and spread them within their own hospital. I think that's the easiest and the fastest and the best way that we're going to get this out to the mass public.
One more question for you. Could you give for our listener there one piece of advice for students, residents, or clinicians that are out there in the actual field related to kind of like this topic of use of these outcome measures?
Yeah, and I tell this to my students when we go over our outcome measure lecture. The one that I teach, they're right about to go out on to their first rotation, and so I tell them the first week, pick one outcome measure that you're comfortable with. That could be, at this point, I say I don't even care if it's the most appropriate outcome measure for that patient, but pick an outcome measure and do it because I think that that's the first step is just pick an outcome measure. Pick one and do it and see how easy it can be. And then as you get more comfortable with different ones and the timing, and like we said, incorporating it into your eval or your treatment or whatever it may be, then you're going to be a little bit better at picking the appropriate one for the appropriate patient at the appropriate time. But the first thing you have to do is just pick one and just do it.
This has been
Just
really
do it.
great,
I love it.
Darby. Yeah. Leo, you think it's time?
I think it is time for our rapid responses. Darby, are you familiar with our rapid responses at the end of our podcast here?
I've seen one or two, so we'll see.
So as the
Or
first thing that comes to mind, shoot it out there.
I'm
Okay.
for the timer and Leo's going to start it. All right, ready and go.
Darby, what's your most favorite scrub color?
Oh, I have to go black.
What's your favorite
All
thing to
right.
eat for breakfast?
Probably yogurt.
Darby, what type of shoes do you wear on acute care?
Oh, look, I'm gonna blank on their name. The Hokas. I will never wear another shoe.
Okay.
Never wear another shoe. Ever again.
Hogas are becoming a thing. What's your favorite way to exercise?
I'm big on the just like walking or like jog around our neighborhood.
Cool. Name a therapist that has been influential to your PT career.
Oh, this is an easy one. Krista Gilly. She was my cardiopulm professor. She was my mentor in residency and now a very good friend, but she's taught me everything I know about cardiopulm.
Are you a
Awesome.
morning person or a night owl?
Oh, morning for sure. My bedtime's like 8 p.m.
What do you like to order on your pizza in terms of the toppings?
I'm a classic, just like pepperoni, cheese, maybe jalapeno if we're feeling crazy, but I'm a classic.
Ooh, spicy
There
girl.
we go.
All right, our time is up, but your last rapid response is, you work in acute care when, fill in the blank.
I would say when you hear like, I had surgery yesterday, right? Like 3 times a day. My favorite. I always just like, do you think we're letting random people off the street into your roof?
I love it.
Like, I know.
Like, you want me to do what? You
Yeah.
know, just literally cut me open yesterday. And it's like, yeah, I know. That's why I'm here. Yep.
Yeah, I'm like, the 80-year-old female next door to you just did it. So I think
I love it. Well,
Do
Darby,
you ever mess with them? I know, do you ever mess with them and just be like, oh, I didn't know that you had surgery. Oh, did you?
like, what?
no,
Right, what? Oh my God.
I have messed with one of my patients, and it was only because, and this may be, like, I don't know if it's frowned upon, but we had this whole conversation before he went into surgery of like what the expectations were after surgery and like what we were going to do. And the next day, he was like maybe a little out of it still, like a little confused. He was like, we should have surgery. And I was like, why did you put all these tubes in you? So, and his wife was just cracking up in the corner because she was there the whole time we were talking about like what was going to happen. And then I was coming in the next day and blah, blah, blah. And so I'm usually like, yeah, I read your chart.
That is fantastic. I
Right.
love it. Well, thank you so much for being with us today. We really appreciate it. We look forward to this core outcome measure set. And for those of you listening, go out and comment on it now while you can.
Yes, please. It's been great. Thanks for having me.
We would like to thank Darby for joining us on the podcast. Acute Conversations is the official podcast of APT Acute Care. It's hosted by Leora Gillis and Ashley Poole. Executive produced by Katie Brado and Edward Benz. Music by Alexia Action from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Bobby Ballerino on enhancing professional education through virtual learning. Thank you for listening, and may your shoes and scrubs stay clean today.
Just pick one and just do it.